earlier, but and he's also interested if you've got any questions. And
so so today we didn't have a topic, so it's open discussion. I just thought of some ideas right now. If you guys have any questions, good to see you. We got a few new people. Welcome. I'm only here once a year, so it's easy to be new for me. So let's see here, just some ideas. In years past, we've talked about, I think, how to talk to your doctor, certain disease processes such as strokes, I think.
Yes.
We talked about end-of-life care, healthcare proxies, things like code status. We've talked about...
you talked about what to expect upon admission.
Yeah, what happens in the acute care hospital if you get admitted to the hospital.
And we've talked about discharge planning, the need for discharge planning. At one point I remember even having a good discussion about sleep habits. Which of course none of us have any problem sleeping at night.
So just as a point of yeah. Oh, sorry. I'll come over here in the corner. So I work mostly in the post-acute care area. So you guys know that my little group, we're based in Boxford over the animal hospital, and we're in 13 SNFs, which are skilled nursing facilities. They used to be called nursing homes, but they don't like being called nursing homes anymore because there's a lot more rehab that goes on. People are getting discharged to the SNFs much sicker than they used to, and where people might stay in the hospital for 5 or 10 days in the past, now they're staying for 3 or 4 days, and then they're going straight to the SNFs or to the long-term acute care hospitals and such.
I should interrupt and just explain again, since we have a few new people. This is Dan Tallman, who's been a very good friend and a wonderful speaker for us for several years. So I'm very grateful because I know you've got a really nice, the schedule's even picked up for you. So it's really nice that when you are able to come out and join us.
I like to smell the food that I can't eat because
even I can remember again when he started speaking with us, his kids were little kids.
Yeah, this was about 10 years ago. I think I've been going for about 10 years.
Yes, you have. Yeah.
So it's fun.
And some of us didn't even have grandchildren at that point that I do now. So I'm really, thank you. I really appreciate taking the time, and it's been a great resource for us.
Yeah.
And next month in June, Jim Lacey is going to come and talk about the work at Camp Dennison. And I thought, I said, bring photos, bring work, and of course you might try to recruit a few people for some additional volunteers. But I mean, that's been a tremendous effort out there, and I thought that would be a nice opportunity to talk about all the progress that they've made, and the volunteer effort out there has been tremendous. All that's been accomplished by just the group of Bobs. But Dan, thank you. Yeah. So we're I could even write down the notes or.
Oh, I like writing. You guys know I like to draw pictures. I'm a big picture person. They're ugly pictures, but they're hopefully you can see what they're meant to be.
And I'll bring out more French toast.
Some things that we were talking. So in years past, we talked about a variety of things. Some ideas that I thought sometimes medications. Some people ask medication questions. Why am I on this? My son's on this. My kid's on this. My wife's on this. What is that? What does it do? Basic medical science. We could talk about. What's a bacteria? What's a virus? Probiotics. What's a heart attack? What's atrial fibrillation? What is COPD or diabetes? Different types of infections. What's a stroke? Things like that. Falls, vertigo, lightheadedness, vision problems, primary care problems. I work in the SNFs, so I'm not a good. What I do is try to fix people's problems after they have a problem. It's not so much primary prevention. So if you guys have questions about what's the best diet to decrease this risk or that risk, that's really not my area of expertise. That's probably what your PCP is going to be better at. Because a good PCP, a good visit is a boring visit. A good doctor visit is super boring. You're doing everything right, you have no problems, and you're eating everything the way you're supposed to and doing some exercise and whatever. But so the PCP's job is to try to keep you from getting sick, and then my job is once people are sick, do what we can do to kind of get them tuned up and ready to go home. So I'm happy to take any questions, but it may not be the best answers. Levels of care, we can always talk. I've worked, I have a practice, I have a colleague who's in practice in assisted livings as a primary care. She's a nurse practitioner. So there's assisted living practice model that we have. We take care of people in the acute care hospital. In the long-term care acute hospital at Whittier Bradford, that's what's called an LTAC. That's actually a hospital level care. LTAC has a transitional care unit, it's called a TCU. We work in skilled nursing facilities. Those are what used to be called nursing homes. We've got short-term rehab patients and long-term care. So the long-term care people that live there. I'm a hospice medical director. So we could talk about what is hospice, what is palliative care. That would be an interesting discussion. Also VNA, visiting nurses, like what exactly do they do and all that stuff. So anything that's interesting or not interesting of the above, or whatever you guys have any questions about. I have to leave at 10:25, so we've got about 35 minutes here. But I'm a big talker. If you guys get anything going, give me anything. I'll go with it.
Now's our chance.
When do you think there's a need for hospice care?
Okay, so hospice care is, for the definition by Medicare regulations, is that normally your disease process would, you would have passed away within 6 months. So your primary care doctor has to certify that they would expect under normal circumstances that you'd be dead in 6 months. Most hospice patients come on board way too late. They come on board and they die the same day, or they die 3 days later or 7 days later. We do have some people who stay on for a year or a year and a half, and what happens in hospice is we have a meeting every 2 months on everybody, and we have to recertify that we're doing something that the patient qualifies for hospice. So the hospice has like chaplains, they've got aides that come and both volunteers that basically just hang around and chat, and just volunteers. They've also got paid medical assistants that can help with medical care. They've got nurses, RN nurses, that come and evaluate your meds to make sure people are comfortable. The goal of hospice is really to make sure people are comfortable and dignified. It's not to fix people up. It's not to get you tuned up enough to for the next lap. So that's important to know, because we're all going to pass away at some point. And I think most of us don't want to be in the hospital if we can avoid it, but we don't want to be in pain, and we don't want to be laying there naked with everybody traipsing in and out. So I think that's a valuable service and something that is worth looking into. People do graduate from hospice, so it doesn't have to be I think people are scared to talk about hospice, but I think primary care doctors may or may not be. The hospice conversation can be a long conversation. So it's something that's kind of harder for the doc to address in an office. If you come into the office and you've got 6 problems, this hurts and I've got this and I'm short of breath and I've got this rash and there's this thing on my, can you burn this thing off? It's going to be harder for them to talk about that. So it's worth going and seeing your doc or your nurse practitioner for a visit just about like, how am I doing overall? What's the big picture here? Because they would be happy to have that conversation. And as I've talked in times past, if you go to your primary care doctor, they really only have time to talk about 2 or 3 things. So if you go with 10 problems, make 3 appointments. Just make 3 appointments, because they'll love to see you. That's how they make money. They make money by seeing you. So come on back every 2 weeks. And probably most of you guys are retired, so why not go visit the doctor? I had a 6-month follow-up with my PCP yesterday, and I went in to go see the nurse practitioner. I'd never seen her before, and I didn't even know why I was coming back, but I had made my PCP said, why don't you come back in 6 months, we'll check on this and that and whatever. So I made my appointment, and I had it on my schedule, and then any problems? I'm like, no, not really. But they found things to talk to me about, a variety of different things. So sometimes it's good to go as just a routine follow-up, because they'll find things to help kind of tune up and work with you on. So hospice, it's a good thing. You can do hospice in the skilled nursing facility or the hospital or in your house. So hospice can be done anywhere. Some hospices, there are financial implications. If you're in a hospice, you should find out about that ahead of time. because sometimes hospice pays for some things and doesn't pay for other things, and sometimes you might get on the hook for a payment for something in one setting level of care, but not in something else. So that's a legit question to ask about, because docs can do hospice stuff in any level of care, but you'll get more hospice attention if you're actually enrolled in hospice. You'll get more. You won't get a chaplain. Like if you're in the hospital and you've chosen, I don't want any more stuff. Let me, I'm gonna probably, die in the next 2 or 3 days. Let me just stay here in the hospital. We can keep people comfortable and dignified in the hospital, but you're not gonna get a social worker to come in and talk to the family about end-of-life planning. You're not gonna get, somebody, chaplain and volunteers and things like that. So they do more support for the family, because you also gotta think about it from your family's perspective, because then there's somebody to talk about them about planning, what your wishes are afterwards, and are they okay, and oh, the son doesn't get along with the daughter and they're arguing about this. Like, sometimes it's nice to have somebody else who can get in between that whole thing. So that's my opinion on hospice. Palliative care now. Palliative care means talking about the goals of care. So somebody who's been in the hospital 5 times, let's say somebody's been in the hospital 5 times in a year. Something's not going right. Something is very wrong with your health. So they might ask for a palliative care consult, and what that is that there's a specialty, palliative care, and they talk about what are your goals, how aggressive do you want to be, because doctoring, we can keep people going for quite a while. We can keep people trundling along. Humans are tough, and we have a lot of things that we can do to keep people going for a while. The question is that what you want? If you're unconscious, intubated in the ICU for 2 weeks, and you're going to die anyway, what's the point of that? Like, because it's probably uncomfortable. I mean, I've never had anybody say, oh, that was no big deal, like, that's easy, I'll do that again. So then that's important to know. People who want, and it's better to plan ahead. If somebody's going to have breathing problems over and over again, maybe it's time to get a trach, because it's much more comfortable to have a trach. Some people, as people age and get sick, you have a problem swallowing. It's very common. You can choke, get pneumonia, things like that. Sometimes, maybe it's a good idea to get a G-tube, a tube where it goes straight in your stomach. That sounds like a huge production and a big giant deal. It really isn't a big giant deal. And if that is the one thing that's going to keep you going, let's say you've had a stroke and you can't swallow, but you've got 5 or 10 or 20 more years of life ahead of you, and you've got grandkids and you've got stuff to do. If that is your one problem and your main risk in life, then you should talk about that with a palliative care doc, because there are a lot of misconceptions out there about lots of things, about what we can do and what we can't do. I think most people think that when you die, you just die like that, and it's really not that way normally. And I think a lot of, so, in the movies, they talk, and then they die like that. That's not usually how it goes. And it just doesn't go that way. So, it's good to talk to people who can kind of set expectations and not, and get to know what you guys want, or any patient, or your wife, or your, some kid who's got cancer or something like that. So that's what I think about hospice and palliative care.
You want to talk about medical marijuana? Medical marijuana.
I like miracle better. So medical marijuana, not my area of expertise. Marijuana, THC, tetrahydrocannabinoid or something like that. I think that's one of the active ingredients. It's not approved by the federal government, so we can't use it in skilled nursing facilities. So you're not going to get any THC, medical marijuana in a SNF or in any kind of a hospital or anything. There is something called Marinol, which is it's got some sort of bioequivalent to marijuana, and it makes you hungry. That's one way that we do use kind of an equivalent in the hospital is Marinol. That stimulates your appetite for people who are losing weight. As far as marijuana, I went to a talk about 2 or 3 years ago, and I think the leading experts in the state were generally against it. I think doctors are generally mildly against it. I do know that reportedly there are many positive uses. I think it decreases pain medication need. I think it decreases nausea, certainly. It stimulates appetite for sure. It is much less addictive than much less addictive than alcohol or nicotine, for instance, and less addictive than heroin and cocaine and such. I also have heard that people who use marijuana, either legally or illegally, use less narcotics, and marijuana is much safer if you're going to have an illegal bad habit. I mean, now it's not legal, but if you're going to have a problem, it's better to have marijuana be your problem than heroin or using oxycodone. So I don't prescribe marijuana. I'm not morally opposed to it. I just don't know enough about it. And it would be like prescribing an e-cigarette as opposed to cigarette. I'm not morally opposed to e-cigarettes. I just don't know enough about them to say you should use that. I mean, theoretically, it should be better than a cigarette because you've got a lot of carcinogens, you've got a lot of smoke, you got you know, oils and things that are burning up in all kinds of bad ways in a cigarette. So, yeah, I'm mildly anti, but not. You know, I could be convinced otherwise, and it's just because I just don't have time to look things up. So if anybody else has more knowledge, I'd be happy to hear it. But usually when people tell me things, I say thank you for your information, and I look it up like in depth, in great detail. Because one thing I've also learned is that when you talk to people about rules or laws, or this is how we do things, or this is why we do things, it's always a good idea at least to go look things up and educate yourself in as much detail as you can. Because I've had nursing home directors tell me, this is how we do things because that's what corporate says, or that's what our corporate lawyer says, or that's how it's done, that's the rule. And I respectfully say, thank you very much, I'll go look it up myself. And 50% of the time, I find out that if you look at the rules and the laws, they're not exactly what they say. They may imply some of these things, but they're not exact. And so I think there's great value in looking things up in detail before you go.
What's the criteria to be on hospice? In other words, if you're in a hospital, you've got great hospital care. What's the difference between a great hospital care as opposed to hospice? How do you determine it?
So hospice, so you have to have 6-month life expectancy, normally. A normal person with your problems most people would expire within 6 months. That's number one, have to be within 6 months. Hospice has about 10 or 15 diagnoses that they're allowed to admit for. So they can admit, and there are different types of dementia that you can admit for. That's pretty common. End-stage COPD, which is pulmonary disease, emphysema. You can admit for end-stage congestive heart failure, different types of, any type of cancer where you've got a documented and pretty reasonable expectation of dying. But you know, some things just like failure to thrive, like somebody's 103 years old and they're just losing weight. So if you're losing 10% of your body weight I think it's 10% every 6 months, then you can qualify for hospice also. So if you're losing 10% of your body weight every 6 months and we just don't know why, I mean, at 103 or 112, you know, people just kind of wind down. So maybe they're getting weaker and they need some support and they would qualify for hospice. That would be a good admission. Can you close that other door also? The reason to stay in a hospital is acuity of care. So if you're in an acute care hospital, the reason is because you've got an acute issue. And one of the major things that you do in an acute care hospital that you don't do other places is a rapidity of diagnosis. If I need x-rays fast or labs fast, or I need intense, like the nurse to patient ratio is higher in an acute care hospital. So when I say acute care hospital, I just mean a regular old hospital, like what you guys would think of a hospital. Because there are other types of hospital too. So if you have some issue that is so overwhelmingly hard to take care of that you need to be in a hospital, then you can be in a hospital. And you can get hospice care in a hospital. If you still need hospice care after a day or two, you haven't died, they would be likely to send you to what's called a hospice house. Hospice houses, there's one in Haverhill, and there's one down in like Danvers or someplace like that.
Danvers.
Yeah, Danvers. And those are for people who need a lot of nursing care. Those people are in bad shape and they would not be able to be taken care of in a home. And usually, in order to admit to the hospice house, in general, I think the life expectancy has to be 10 days or less. But I do know that people can stay longer. But generally, you have to say we would expect about 10 days. And that's people who are bleeding a lot, who've got lots of wounds, tons of pain, like that kind of thing. So You can take care of people on hospice in the hospital, but it's more the acuity of care. And in the hospital, the nurses aren't hospice nurses. You're going to get better hospice care at the hospice house. And most people who have on hospice, if they're, either the patient or the family, if possible, generally like to have them at home if possible, if you can make it work.
So a follow-up, if you're lucid, you're in a hospice care, if you're lucid, to make a decision, you say, I want to be made comfortable, how do they give you enough painkillers, but they don't give you any support? Is that it?
Morphine.
You'll just pass away quicker, right?
So let's say you're in the hospital. Are you talking about hospital or just hospice in general?
Hospice in general.
Okay, so hospice in general, let's say that you've got cancer, you're with it. You are with it and you've got cancer and you're losing weight and you're in pain because you've got pancreatic cancer and it's burning up your stomach and it's eating through and it's in your bones and it's metastatic and you've got pain everywhere. So now, in the past you were on high blood pressure medicine. We don't need that. Like, we don't need any more high blood. If your blood pressure is 180 over 100, you're not going to die of that. The reason why we keep blood pressure low is so people don't have strokes and heart attacks, yes, but also years down the line, it reduces your risk of heart attack in the future. So preventing badness is something we do in medicine. But once you're in hospice, like, we don't have to worry about your cholesterol, right? But we would keep you on your laxatives, because who wants to be constipated when you're dying? Especially now you're going to be getting lots of pain meds, which cause constipation and confusion. So on hospice, we would stop things like cholesterol. Traditionally, we would stop things like cholesterol meds, aspirin, like aspirin to decrease heart risk and stroke. We would stop things like if you had vitamins, multivitamins.
So I think what you're saying, if I hear you right, they won't try to maintain your life expectancy, but they will try to keep you comfortable.
Absolutely, yeah.
Okay.
So if pain is your problem, we can help you out. We can fix you up.
I'm asking this. I have a friend who's he's calling him 260. Now he's down to 134 pounds. He's been going through radiation and chemotherapy for 3.5 years. And he had a tumor removed in his stomach. I hardly recognized him when I went to see him. But I think that's what they're doing. They're trying to keep him comfortable. They're not giving him any life support to do things.
Yeah, so radiation, like in hospice, you can get radiation if it makes you comfortable. If you have an obstructing cancer in your lung or in your intestines or something and it's obstructing forward movement of food or you can't breathe, they'll give you palliative radiation to decrease the size of that cancer so that you're more comfortable. So it's not like you can't get chemo or can't get radiation, but people kind of decide on what they want and what they don't want, because those things can be uncomfortable. Chemo can make you nauseous and just feel generally bad. Radiation, you can get burns and it can be uncomfortable. You can have side effects from radiation also. So hospice is, comfort and dignity. That's what it's all about. People, family members, we do have family members that say, boy, mom really wants to stay on her Coumadin for her AFib, but she's on hospice. And for me as a doc, your general risk of a stroke in AFib is about 3% a year on now that's about, it depends. The more risk factors you have, the higher your risk. If you've got cancer, your risk is higher of a stroke. So maybe it's 5% per year. So let's say mom has 3 months, let's say mom is looking bad and she might have a month or 2 left. And you want, so I would say as the hospice doc, why put her on Coumadin? Because we have to check her INR, we have to poke you. That's another pain thing that we're doing to you. And we're not really extending your life that much. It's 2 months. Your risk of having your 5% annual risk of having a stroke in the next 2 months is 0.6%. Okay, and let's say you did have a stroke. Okay, I mean, she's dying of something, and she had a stroke. I mean, at some point, you're just dying. Like, whatever you die of, that's what you're going to die of something, and it's going to happen in the near future. So family members can override. They can give us their wishes, and we'll go for it. Now, that type of thing, though, that would be where the family has to pay for Coumadin, which is very inexpensive. But there are other meds that are more expensive. We do have family members who want their family members to be on Coumadin or, a variety of things. Like, so you can demand to stay on certain meds, but most, in general, the medical director of the hospice company will say, we would recommend stopping these 5 meds, continuing these 5, and we'll give you extra. And then you've got, at home, they would have a kit with like morphine and anti-nausea meds and things like that. Or morphine or not morphine, like oxycodone pills, if you could swallow pills, that kind of thing.
Is hospice a 24/7?
Yeah, absolutely. You call hospice, those people will be out there. They're not there at your side 24/7, but they're there. They'll come out if you are looking bad. They will come out anytime, 24/7. Those nurses are amazing. They get out there and they are dedicated. You've got volunteers, so they're not going to be there 24/7. You've got the chaplain who goes around, and some people want to talk to the chaplain, some don't. You've got a social worker, and then you've got medical assistants. And if your problem is at night, you've got major problems at night, and you're, whatever, they can put people on overnight. But generally it's not 24/7, but it can be pretty intense, especially as people are really nearing the end of life. They can really turn up the heat on that, or the gain, or the volume, or whatever you want to say. Turn up the tension. So any meds? Who's got a cousin or a nephew or a niece or a wife or somebody that's on a strange med that you're any questions about? Or stroke? What's a stroke? What's a heart attack? What's anything?
There's 2 types of strokes.
Yep.
What's the difference between
Ischemic and hemorrhagic. Yeah. So 85% of strokes are clotting strokes, and 15% of strokes are bleeding strokes. So the first thing that happens when you go to the hospital is they do a quick CAT scan. A CAT scan with no contrast, because CT scans, which is computed tomography. So a CT scan is able to see blood very, very, very well, and it also sees calcium, so it sees bones well. So if you're looking for a fracture or something like that, CT scan is the way to go. If you're looking for blood, CT scan is a great way to go. So the first thing they do is put you in the CAT scanner quickly to see if you've got a bleeding stroke, because if you have a bleeding stroke, you don't want to cause more bleeding by giving them something that causes bleeding. But 85% of people have clotting strokes, so the treatment initially of most strokes is going to be giving you something that is a thrombolytic. It breaks down the clots, or it's an antiplatelet medicine or something like that. If you present within 2 hours, and right now they're changing the guidelines as far as how far out they can give you these meds that help with anti-clotting. I think that they're going from like 2 hours to 3 hours right now, because what happens is if you give somebody, if all of a sudden, right now, somebody has symptoms that are consistent with a stroke and they go to the hospital, and we know when it started, they can give you this clot buster, and it can fix you up, it can cure you, but it can also cause bleeding in other places.
What happens to the clot? If it gets into the lungs, you'll have an embolism, right?
Well, so your clotting cascade in your body, if you think of it like a teeter-totter, that's really how you should think about it, because we're constantly clotting everywhere, and then we're breaking down those clots all the time. So it's a balance. So when you take aspirin, or you take a little bit of Coumadin, or whatever it is that you're taking, it just alters the balance a bit. And we can alter the balance a lot by giving you subcutaneous heparin or things like that. We can make the balance change significantly immediately. But when you're taking pills in general, it's to change the balance to some degree, because you're at more risk of, most people are at risk of clotting. Most people would be taking aspirin a day. Aspirin is very common. The clot, so you've got different types of clots also. The clots that you have in your brain are generally, they're going to be either your arteries are slowly closing, because as we eat more cholesterol and age, calcium and fat and glucose, if you've got diabetes, the sugar gets in there, and sugar is like literally sticky in your bloodstream. If you've got too much calcium, too many platelets, sticky blood, you've got cancer, you've got some reason to be hypercoagulable, you've got diabetes, you're going to be getting more and more clot buildup in your arteries until they get too small.
So will the aspirin help for that?
Yes, aspirin would help for that.
What happens if you're allergic to aspirin?
Then you wouldn't take aspirin.
Is there anything you can take?
Yeah, you can take Plavix. You can take
what?
Plavix is something that works similarly to aspirin. So aspirin works on the platelets. The two most common ways that your body clots are with platelets or with the serum, the liquid, the clear liquid that you'll see sometimes in your blood. That's called serum, plasma, and that has the intrinsic, so there's fiber in there that's floating around, and if you activate these cascades, the fiber can glom together and create a sticky mesh that then the platelets come in and stick in on, and then you get a scab, or if you cut yourself, it'll bleed for a bit and then it'll stop. So the aspirin or Plavix work on the platelet side, and then you've got heparin and Lovenox and other types of medications, both injectable and oral pills, that work on the pathway that's in your serum. The answer to your question about clots in the brain, though, is that there are different types of strokes. There are many different types of strokes. One type of stroke is where an artery just closes off. It closes off, and then you get a stroke in that area. So that's one kind of stroke, and that's not uncommon. That kind of stroke, it may respond to a clot buster. That's a good one that will respond. That may or may not respond to a clot buster. If you go in and they see that it's the kind of stroke, they can actually go in and put stents in certain arteries if they're big enough. Now, at the base of your brain, there's something called the circle of Willis, and you've got four big arteries that go up and allow your blood to circulate through, so that you get good distribution to your whole your brain. So if you've got a big arterial problem, sometimes you can go use a stent to open it up, or you've got your natural, your carotid arteries and such that feed this circle of Willis. You've got other kinds of clot. You've got other kinds of strokes. You can have a bleed. Another kind of clotting stroke would be atrial fibrillation. People with atrial fibrillation get clots in their left atrium because it's not beating correctly, and the blood sits there and just coagulates in the, there's a little appendage on the left atrium.
So backing up a little bit, if you have a clot,
a true clot will probably be a
true clot in the brain,
it's probably
take a 325 milligrams of aspirin, what will that do for you, if anything at all?
So when your body sees a clot that's not supposed to be there, it starts to break it down. So your body is going to see this clot in your brain and say, this is not where this clot's supposed to be, and it's going to start breaking it down. So if you give aspirin, then that can help break down this clot more quickly. Aspirin permanently disables the platelets that it touches. So when you take an aspirin, it stays in your bloodstream for about 8 days. Aspirin, not aspirin Tylenol, not aspirin ibuprofen, aspirin.
Bayer aspirin.
Bayer aspirin. Because a lot of people call aspirin a lot of things, like anything that's a pill that takes away fever is aspirin. Yeah. So I'm talking aspirin. The platelets that it touches, it disables those platelets for good, but your body's constantly making platelets, and the natural turnover for all your platelets is about 8 days. So if I took an aspirin today, later today, tomorrow, I would have the maximum effect, and then every day after that would be lower. And that 81 milligram aspirin that I'm taking doesn't affect all my platelets. I still have some platelet function, but it's less. So if I take a 81, so if you have a stroke and you don't get there within, either you're not a candidate for TPA, that's the clot buster. If you're not a candidate for that because you came in too late or it's the wrong kind of stroke, but they give you an aspirin, they might give you an 81 milligram aspirin initially because you've had one stroke and they don't want, and they might make sure your blood pressure is under control, you don't have diabetes, your cholesterol is under control, and even if it's under control, they might give you a low-level cholesterol medicine just to get it lower.
If you have a bleeding,
no aspirin for you.
You took aspirin, it would exacerbate the condition.
It would be worse. Yeah, exactly. So, clotting strokes, you can have endocarditis, which are infected clots from the heart. Those are pretty uncommon. Pretty uncommon. You could have atrial fibrillation that causes clots. You can have arteries that just close down from high blood pressure, diabetes, bad circulation. There is a I can't remember what kind, but as your brain ages, you're also more predisposed to just having spontaneous bleeds in the brain itself also. Those are kind of not good to have because they can recur over and over again. And then in the bleeding stroke category, you can just have bleeding strokes from, you know, intraparenchymal, like I was talking about, where it just bleeds into the actual part of the brain. If you fall, you can have subdural hematomas. You can have bleeds of kind of traumatic. Those are easier to fix because you can just drill a hole in your skull cap and drain it out if you get it in time. Yeah, the neurosurgeons, they do a burr hole and you can drain those.
Is that similar to an aneurysm?
So an aneurysm is when you know how in a water hose or a tire, when it starts getting bulged out, because of physics, more advanced than I can tell you, as the bulge gets bigger, the pressure actually gets greater on the weak parts. So aneurysms, doctors will monitor your aneurysm either monthly or every 3 months or 6 months or yearly or whenever, because as they get bigger, they're at more risk of getting bigger faster. So it's kind of like a slide, you know. Initially, it's not going fast, fast. So there's a point at which they say yes, you need surgery, or no, you don't. In these, you can have aneurysms anywhere. They're not all catastrophic. They can be. So you should know about those. There's a lot that they can do for a lot of these aneurysms. Some of them they can put little sleeves on the inside that supports this. Sometimes they have to go and do surgery and cut out part of it and put a fake part in. A lot of aneurysms are abdominal aortic aneurysm, and the problem with the abdominal aortic aneurysm is that it's from about here to here, and your arteries to your kidneys come off of that. So a lot of times, not a lot of times, but sometimes, if you fix those, you can have problems with kidney damage because you have problems with circulation back to your kidneys. But that's all the vascular surgeons. Those guys are really good at that. They know the numbers. That's why you go see those people, because there's a specific number, and we're trying to get your blood pressure lower to decrease the risk of that. So that's very exciting. Yes, sir. Oh, wait. Here, you had 3 questions. What's your question?
Question.
Comment. Complaint.
He dress himself for a doctor as a fool for a doctor.
That's right. Don't treat yourself. So, and my wife has a saying. There's a saying in German where the shoemaker's children have the worst shoes. Yeah, seriously. In my house, if some kid tells me I feel sick, I'm like, you're not sick enough. You're not sick to me. Go to school. I mean, I don't want them to cough on the other kids, but you know, they got to be pretty sick not to, you know, to impress me. Yes, sir.
I had a double aneurysm in the brain.
Mm-hmm.
And they cut one main out over here.
Mm-hmm.
And that solved that. But the other one, I just had to go in and pack all around it, and it was good luck. You hit 65, you're doing good.
Mm-hmm.
Well, I'm 83, so I didn't do too bad.
Yeah, so, you know, if you've got an aneurysm, it's this bulge in the tube. So, and they fix if they're going to do stenting, if they can't like cut into your brain, then they have to fix it from the inside. So they'll put something on the inside, and then you've still got this bulge on the outside. So they have to staple it in or wire it in somehow, but you've still got this other bulge that could grow. And I have to think that they use some method to get it so that it destroys the outside part, that's the aneurysmal part, and your blood is circulating through the new stent. But that's way beyond my area of expertise. Oh.
My dad had an aneurysm problem with belt, and he gave the most of 1% chance, but it did not. It kicked his Alzheimer's. Yes,
Alzheimer's is bad. So abdominal aortic aneurysms are usually catastrophic. There aren't a lot of things that will just kill you instantly. You're walking along, minding your own business, and you just keel over dead. Catastrophic strokes, which most aren't. Most strokes aren't like, you don't just keel over dead with most strokes. Usually you have, either it's a mild stroke or severe and you have residual deficits. So people who say, I'm just going to die of a stroke, you know, I'm not going to treat my high blood pressure, I'm just going to have a stroke and die. You don't just die like that. You don't just keel over. I mean, I wish people, I wish I would just when it's time to die, I just die. One second. Yeah. The abdominal aortic aneurysms, if they do pop, I mean, it's not like they explode, but they will rip open. And then most people who have aneurysms, it's because their arteries are hardened. And once your hardened artery opens, it doesn't clot very well, and the pressure is pretty high. You do have fascia, and your whole body's around that area, so you can tamponade that off. Once you lose enough blood, if it can't keep spreading, the blood pressure on the outside is going to eventually stop the bleeding, Now, we only have about 6 liters of blood, so it depends on where it's bleeding. So if it gets into your abdomen, you bleed out. But if it's someplace where it's behind the the firmer part of the fascia and such, it could tamponade off. But yeah, it's not a great way to go. They brought him?
They brought him back, he died on the operating table with an aneurysm back.
Yeah, aneurysms are not good.
He said he watched the whole thing from the Zoom.
He watched it?
He said he watched the whole operation from the Zoom.
Yeah. And also, anybody who's got Alzheimer's, anything that makes you a little sick can tip you over the edge and get you more confused. That's pretty common. So another thing that people don't realize is that people will compensate until we decompensate. And that's a hard thing for family or for we ourselves to appreciate. If you have bad vertigo and you just deal with it, after a while, and so the way that you can keep your balance is your vision, your proprioceptors, which are nerves in your joints that tell you where you are on Earth. They're reflexes that keep you up, and also your cerebellum and your inner ear. So if you take out the let's say you've got bad vertigo all the time, and you're a little bit dizzy all the time, but then after a while you get over it because your joints are still working. Oh, stop talking. Your joints are still working, and your vision is okay. Then you're still walking around. But then let's say you get a little bit of a cataract, or you've got diabetes and you can't see as well, or you've got diabetes and you've got mild nerve damage and you can't feel anymore. Then you start falling, and you're like, why am I falling? What's wrong? Blah, blah. You'll compensate till you decompensate, and that's hard for people to, Dad was fine until last week. Well, he wasn't really fine till last week. He was just compensating until something happened. He got a cold, or he got, had a little mini stroke or something, and now he's not fine. And so Alzheimer's really can get exacerbated significantly by little tiny things. Urinary tract infections, staying in a different location with a different child, moving locations, anything like that. Okay, last question.
Last one, hypothetical. Insurance probably wouldn't pay for it, but all these things we've been discussing, different issues. If you had an MRI from your waist to your head, would it address some of these things you're talking about? Insurance wouldn't pay for it, but...
A good example of why to do things and why not to do things is probably the whole world of the prostate cancer screening. So prostate cancer screening. So the question is if you know, theoretically, every single man over the age of 90 has prostate cancer to some degree. That's normal. So the question is how much, and is that what you're going to die of? Most do not die of prostate cancer. It doesn't obstruct anywhere. It doesn't grow in the wrong place. It doesn't metastasize. It's just what it is. So then the question is, at what age do you start screening, and how aggressive do you want to be? Because some of the interventions are not good. They can put radioactive little capsules in your prostate, and it burns away some of the bad tissue. But you can have problems with holding your urine. You can have surgery. You can have all kinds of surgeries. You can have urinary incontinence. What was that?
Green light laser.
Green light laser. I'm sure that they're coming up with all kinds of good stuff. But the point is that you can intervene. You can cut out the whole prostate. But you can also be impotent and incontinent and in pain and infection. So what medicine will do is we'll do studies over years, and we'll say, is it better, like at what age do you start screening, and is the intervention worse than the problem? And as we come up with new treatments, it'll change the answers. So that's what's frustrating to lots of people, because people are saying, you medicine people, you're constantly changing your opinion on stuff. Well, I hope so, because back in the day, in World War II, all we had was penicillin. That was the answer for everything. But now we've got all different, we are medicine is constantly changing, so the answers are changing all the time. So the question about whole body scanning is first of all, if you're going to scan everybody, MRI is 2.5, 3 times as expensive as a CAT scan. What would you pick up, and would you be causing more damage by intervening in things that would normally not be a thing? Like, would you find things and nodules and cysts? because we got cysts in lots of different places, and most of them are benign. And so then are you going to start doing biopsies, and then you've got people going to the hospital and they're nervous and they get depressed, and some commit suicide, or some just get depressed, or some get biopsies and then they get infections, some get biopsies and then they have surgery and they take it out and oh, it's benign, and then they get infection,
So
or they've got...
the cure is worse than the disease.
It may be.
Yeah.
Now, I think that CAT scanning on people who have a certain number of pack years of smoking, I think that that might be something that's happening in the future. I think that there is some discussion at what point do you start doing some sort of baseline in x-ray or not, at what age, how many pack years. So that's a legit, I mean, just because right now it's not the standard of care, it doesn't mean it's not going to be the standard of care in the future. Because as we get better interventions and treatments, maybe it's better to find things out, you know? So everything's in flux all the time. That's my talk, gentlemen. We made it work for 45 minutes without any kind of thing.